Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 542 of our pharmacotherapy series, which majors in bipolar disorder. This part of the series involves patient TCR from part 541 of this pharmacotherapy series. If the nerve pills borrowed by TCR were antidepressants, could they have contributed to the development of his manic episode? Antidepressants are commonly prescribed for patients with bipolar depression, that is 35% to 40%. Their use is controversial, though, with criticisms that they lack efficacy or that they destabilize mood and can cause a switch to mania. All of the major classes of antidepressants, including monoamine oxidase inhibitors, tricyclic antidepressants, abbreviated as TCAs, selective serotonin reuptake inhibitors, abbreviated as SSRIs, and serotonin and norepinephrine reuptake inhibitors, abbreviated as SNRIs, have been associated with precipitating mania in patients with bipolar disease. Despite this risk, up to 50% of patients with bipolar disease are treated with antidepressants, of which only half are receiving a concurrent mood stabilizer. There are numerous case reports of mania or hypomania with antidepressant treatment, but few controlled studies, making it difficult to make comparisons across antidepressant classes. A comparison of the monoamine oxidase inhibitor, tranylcypromine, and the tricyclic antidepressant, imipramine, found a similar rate of treatment-emergent mania, that is 21% and 25%, respectively. A meta-analysis found a higher switch to mania rate for tricyclic antidepressants, that is 11%, than for selective serotonin reuptake inhibitors, that is 4%. A controlled trial with bupropion, sertraline, and venlafaxine, all in combination with a mood stabilizer, found an overall switch rate of 19% during acute treatment and 37% during the continuation phase of the study, with no difference among agents. Antidepressants may also cause cycle acceleration, which effectively decreases the time between mood episodes. The risk for cycle acceleration may be heightened for patients who experience manic or hypomanic symptoms on antidepressants despite receiving antimanic treatment concurrently. Other recent literature has suggested that adjunctive antidepressants to mood stabilizers versus placebo are not associated with an increased efficacy or with increased risks of treatment-emergent effective switches. In the case of TCR, an antidepressant may have precipitated the manic episode or shortened his cycle, moving him into an episode of mania from a pre-existing state of depression or euthymia. Any patient presenting with an acute manic episode should have a review of medications completed to determine the risk of continuing antidepressant medications. Current guidelines state that the dual-action monoamine reuptake inhibitors carry a greater risk of precipitating a switch to mania than single-action drugs. Additionally, they state that antidepressant medications appear unlikely to induce mania when used in combination with a drug for mania. The next question reads, why does TCR require treatment? Manic episodes have a number of severe complications. Left untreated, severe mania can result in confusion, fever, exhaustion, and even death. The impairment in judgment, the excesses, and the risk-taking that occur during manic episodes may be devastating. Detriments to relationships, careers, and finances and physical harm or loss of life may occur. Manic individuals may engage in illegal activities or behave in a manner that result in a violation of the law. TCR drives recklessly, may have lost his job, spends excessive amounts of money on gifts, clothing, and automobiles, and plans to participate in a variety of money-making schemes. He has acquired a great deal of cash suddenly, perhaps from withdrawing all of his family's savings or from some type of illegal enterprise. Manic patients may engage in risky sexual encounters, leading to infection with sexually transmitted diseases including human immunodeficiency virus. Alcohol and substance abuse are common and may exacerbate or even precipitate mood episodes. Irritability, such as that demonstrated by TCR, can lead to episodes of violence, resulting in potential harm to the patient or to others. The goals of treatment are to reduce the severity and duration of the current mood episode as well as to prevent recurrence of future episodes. The next question reads, what is the appropriate treatment for TCR's acute manic episode? Depending on the type and severity of mania, first-line treatment involves selecting from lithium, valproic acid, atypical antipsychotics abbreviated as AAPs, or a combination of these agents. If psychosis is present, an atypical antipsychotic would be an appropriate choice either as monotherapy or in combination with a mood stabilizer. Valproic acid is an ideal choice for TCR considering the rapid onset, tolerability, and the established efficacy of this agent for preventing future mood episodes. So there you have it, our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom, and if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 543.